Hi and Assalamualaikum. My name is Aisha Nadira and I am from Group 6 along with Saraya Diha, Aina Yasmin, Usha and Yusuf. We'll be presenting our article which is the estimates of the global burden of cervical cancer associated with HIV. To start off, I will briefly explain about cervical cancer. Cervical cancer usually starts in the cell of the cervix. The cells of the cervix go through changes, also known as dysplasia, in which the abnormal cells begin to appear in the cervical tissue. And if the cells is not destroyed or removed, it may become cancer cells and starts to grow. The cervix has two main parts. The ectocervix, which is also called exocervix, is the outer part of the cervix that can be seen during a gynecological exam and is covered with thin flat cells called squamous cells. The second part is the endocervix, which is the part that connects the vagina and the uterus, and is also covered with column-shaped glandular cells that makes mucus. Most cervical cancers begin in the transformation zone where the endocervix and the ectocervix meets. There are many risk factors of cervical cancer. First, infection with human papillomavirus HPV. It is the main cause of cervical cancer. It is a virus that is passed from one person to another during sex. The next risk factor is smoking. Women who smoke is about twice as likely to get cervical cancer compared to those who don't smoke. It is because the substances in the smoke can damage the DNA of cervix cells and may contribute to the development of cervical cancer. Smoking also makes the immune system less effective in fighting HPV infection. Last but not least, infection with HIV. The virus weakens the immune system and put people at higher risk for HPV infection. In women with HIV, a cervical precancer might develop into an invasive cancer faster than any normal. The incidence of cervical cancer is highly reported in resource-depleted geographical areas. These areas commonly lack in transportation and medical care infrastructures that impose barriers to cervical cancer control. These areas also have population characteristics that put women at greater risk for developing and dying from cervical cancer, such as low income, lack of health insurance, and physician availability. So this study aims to provide an estimate of the relative risk and number of cases of cervical cancer among women living with HIV and attributable to HIV based on UNAIDS HIV prevalence and GlobalCan cancer estimates for 2018.
I'm going to explain regarding methods which they use to investigate the relationship between the HIV and also the cervical cancer. So there were three types of methods which being used. So let me explain the first one, which is the identification and selection of the relevant studies. So the criteria they included in this first method is they use actually 5 different types of database to compare the studies. And the second one is they did not set any kind of restriction, which either based on the language or the year of the publication. So as for the study type, we can see that there are 3 different type of studies were presented. The first one is HIV and AIDS. The second one is cervical cancer, and the third one is epidemiological study. So based on the HIV and AIDS, it is found out that they obtained the last number of studies regarding HIV and AIDS based on their data collected. So as for the cervical cancer, this data actually was collected by the International Classification of Disease, where they actually considered 5 types of ratio to compare the presence of or the absence of HIV disease, which included in the cervical cancer as well. So there are 5 different types of ratio, which is the risk, odds, hazard, standard incidence, and incidence rate. So the third one is epidemiological study, where for this study, it actually simple. They just include 3 different type of factor, which is cohort, case control, and registry linkage study. Okay. So let's move on to the second method, which is data extraction and the risk of bias assessment. So based for this method, they only use 1 study source instead of 2 because it wants to avoid the inclusion of the similar patient case. So between those 2% who collected the data, they only choose one study case. So this for this method, they involve 2 kind of things, which is study and also bias. So based on the study, there are 2 criteria which included, which is the factor and the purpose. As for the bias, they only include the factor that affect the risk of bias. So based on the study, we have 2, which is factor. For the factor, it only depends on the longest follow-up and also the largest sample size. So why does the studies need to be conducted? So that's where purpose of study, where they actually wanted to calculate the pool of the risk ratio. So it's just like similar how they did for the cervical cancer, the effect risk of bias. So this was actually based on the Newcastle, Ottawa, which used as an observational studies. They obtained the result where if the results are below 8 star, so it actually represent a high risk of bias where these 2 cases were between the HIV and cervical were related. So let's move on to the final method, which is the estimation of the HIV prevalence and cervical cancer. But this time they only focus on to 2018 because they did not consider the year of publication, right, for the first method. So it's actually based on that. Based on the factor, there were 2 types, which is the age of the woman and also the country of the territories. So age of the woman, they more focus on to picking 15 years above, where they discovered about 170 over 184 women. They were obtained HIV based on the units. So UNITS is a kind of organization that actually discovered that this fact. For the country and territories, This data was actually collected by the International Agency for Research on Cancer, IARC, where they actually discovered 3 different cases. The first one is only involves cervical cancer, where 185 countries were involved. The second one is a combination of cervical cancer and HIV cases, where 170 countries were involved. And the third one is the one that recorded without HIV cases, and also the last case for cervical cancer, where it only involved 15 countries.
For statistical analysis, random effects model was used to calculate the estimation of the overall risk ratio (RR) for cervical cancer. A random effects model is a special case of a mixed model to estimate the effect of the individual specific characteristic. Next, I-square index was used to analyze heterogeneity across studies. The estimation of the pool risk ratio and HIV was propagated by using a simulation-based approach. Therefore, the proportion of women with cervical cancer living with HIV and population of attributable fraction (PAF) for each country was calculated as below formula. As you can see in the slide, there are 2 types of formula, which the first one is the proportion of women with cervical cancer living with HIV. For the second formula is the population attributable fraction (PAF). Incident rate for cervical cancer attributable or not attributable to HIV were yielded when the incidence of cervical cancer per 100,000 were multiplied by PAF. PAF is population attributable fraction. All countries were analyzed and the results were integrated into regional and global estimates reported by country, WHO region, UNAID regions and UN Africa sub-region. And the last one, world maps were created to portray the 5 levels of estimation by country. The figure shows risk of developing cervical cancer among women living with HIV by type of study.
The included studies were done between 1981 and 2016 and were located in 17 countries. It's located on 4 continents, which are Africa, Asia, Europe, and North America. More were registered linkage studies, followed by cohort studies and case control studies. 19 studies were considered to have a high risk of bias based on the Newcastle-Ottawa scale. So based on the table, we could see in global it have more than 500,000 of cases stated in 2018, but we want to highlight the highest number of cases of HIV and cervical cancer in women are in Africa. Why? We stated here that Eswatini had the largest proportions of women with cervical cancer living with HIV, followed by Lesotho, Botswana, South Africa, and Zimbabwe, and most of the states is in Africa. In 2018, an estimated 4.9% of all cases of cervical cancer globally were attributed to HIV, ranging from less than 1% in the Western Pacific region, and then the 9,490 cases, 95%, and the Eastern Mediterranean region. So here's the cases of cervical cancer in Africa region alone accounted for 85% of cases attributed to HIV.
Now we will focus on the discussion part of this article. The result of the 24 individual studies shows that HIV positive women have a 6-fold higher risk of developing cervical cancer than their HIV negative counterparts. Globally, 6% of new cervical cancer cases in 2018 were among HIV positive women, and 5% of all cases were due to HIV infection. Women with cervical cancer in Southern and Eastern Africa have the greatest share of this burden, at around 64 and 27 among women living with HIV in these regions. This picture shows population attributable or fraction of women with cervical cancer living with HIV in 2018. Reason for increased risk among HIV women include many factors. First, women living with HIV are more likely to develop HPV infection. This is due to HPV virus has a chance to cause cervical cancer, since HIV patients are less likely to get rid of the infection. This will contribute to higher rates of resident HPV infection in this population. Population-wide screening coverage is very low in these areas. The World Health Organization suggested 2 ways to prevent cervical cancer. First, cervical cancer screening, HPV vaccination, and last one, they said both ways are affordable. Why screening is important? Screening is the main strategy to reduce cervical cancer incidence by detecting precancerous lesions that can be treated before evolving to cancer. Screening strategies recommended by the World Health Organization include visual examination with acetic acid and HPV DNA testing. HPV testing shows superior performance when compared to cytology or visual examination. Women living with HIV should have clinical appointments at least every 6 months. This will provide an opportunity to provide interventions for cervical cancer, screening and treatment, along with appropriate follow-up. Benefit of HPV vaccination. HPV vaccination has a key role in the prospect of eliminating cervical cancer. Districts that were the first to implement HPV vaccination programs reported lower prevalence of HPV types 16 and 18 infections and lower incidence of genital warts and precancerous lesions among young women. The vaccine can prevent genital warts, anal cancer, mouth, throat, head and neck cancer in women and men. Data presented in this article has two major limitations. The first limitation of the data is that although they calculated the pooled overall RR estimate, the statistical heterogeneity of the included studies was significant. Furthermore, the author did not find significant regional difference. The second of the data is that the data analysis was based on estimates of cervical cancer and HIV, which may not be accurate for countries without adequate control information. A final limitation of this study is that not all data are stratified by age.
In conclusion, women living with HIV have a 6-fold higher risk for developing cervical cancer compared to those women without HIV infection. It is estimated that nearly 5% of all cervical cancer cases worldwide are attributable to HIV infection. Southern and Eastern Africa and some countries in Western Africa have the highest attributable fraction to cervical cancer. It is important to improve the access to cervical cancer prevention for all women, such as HPV vaccination and cervical cancer screening. Countries with the highest burden of HIV attributable cervical cancer must be approached first in order to achieve WHO 2030 scale-up targets of 30% coverage of vaccination of girls, 70% coverage of screening, and 90% coverage of treatment eliminating cervical cancer as a major public health problem, and reversing the widening disparities in the disease burden today.